Okay, hi. The topic today is goiter and MNG. The term goiter arises from the Latin word gutter that means the throat. It's a generalized enlargement of the thyroid gland. Okay. This is an enlarged thyroid gland. This is a goiter. And why is it a goiter? The swelling moves with deglutition. Okay, you cannot see that in that picture, but it moves with deglutition. Why does it move with deglutition? You know the answer, right? The inferior constrictor muscle has two parts, the thyropharyngeus and cricopharyngeus. They are attached to the thyroid and cricoid cartilage respectively. So when the patient swallows, the muscle contracts and the thyroid and cricoid cartilage moves up. Another reason is the Berry's ligament, which is attached to the cricoid, which is a condensation of the pretracheal fascia. So again, the thyroid gland will move up and down with deglutition. So that is the reason that it moves with deglutition. The another thing is the swelling occupies the normal position of thyroid, and the swelling is deep to the deep fascia and sternocleidomastoid. That is when the patient stretches the neck, the swelling will become less prominent. Okay, so that is why it is goiter. Okay, this is the classification. It is given in Bailey. This is the classification of goiter. There is simple goiter, that is diffuse or multinodular, toxic, diffuse multinodular or toxic adenoma. Diffuse toxic is known as Graves' disease, whereas multinodular toxic is known as Plummer's syndrome. Then it could be neoplastic, benign or malignant, or inflammatory. Okay, this is a simpler chart so that you'll understand. The enlargement of thyroid, they can be diffuse or nodular. Diffuse diffuse or nodular. Again, nodular could be single or multiple, single nodular goiter or multiple. And again, either ways, even if it is diffuse or nodular, it could be euthyroid, hypothyroid, or hyperthyroid. Okay, so a goiter it can either be diffuse or nodular. Nodular could be single solitary thyroid nodule or a multinodular goiter, and either ways, any of those diffuse or nodular could be euthyroid, hypothyroid, or hyperthyroid. Okay, this is also another chart to show you. Non-toxic goiter, diffuse multinodular or nodule, recurrent. Toxic also can be divided in the same way. Neoplasm could be papillary, medullary, follicular, anaplastic. Inflammatory goiter is Riedl's, Hashimoto's, Decuverin, and there are other rare causes. WHO grading of goiter is grade 0, no visible or palpable goiter. Grade 1, there is palpable thyroid goiter but not visible, and grade 2 is visible. Now, coming to the etiology of goiter, it could be physiological. There could be a minor increase in the size of thyroid gland during puberty or pregnancy. Endemic, due to iodine deficiency. Dishormonogenesis, which could be familial or due to thyroid peroxidase deficiency. Goitrogens, such as cabbage or cassava root. Drugs like sulfonamides, iodides, lithium, amiodarone, cobalt, and also previous radiation to neck. These are the common etiological factors. There are other factors as well, but common. Okay, we mentioned that there is an inflammatory cause as well, right? So these are the usual inflammatory causes. There could be autoimmune causes like Hashimoto's thyroiditis or chronic lymphocytic thyroiditis, granulomatous as in Decuverin thyroiditis, fibrosing that is Riedl's thyroiditis, and infective and other causes of inflammatory thyroiditis. Okay, now the pathogenesis of goiter. Initially, there is persistent growth stimulation which leads to diffuse hyperplastic goiter. At this stage, it is reversible if the stimulation ceases. That is, if it is hypothyroid, you can give thyroxine supplements, and that way the stimulation ceases and goes back to normal. This is reversible. Later, as it continues, there is mixed pattern with areas of active and inactive lobules. The active lobules become more vascular and hyperplastic until hemorrhage occurs, and then there is a central necrosis, leaving a surrounding rim of active follicles. Okay, this is something you need to know. The pathogenesis is important. Necrotic lobules coalesce to form nodules filled with either iodine-free colloid or inactive follicles. There is continuous repetition of this process, and at the end, the important thing you need to know is most nodules, they are inactive in the center, and active follicles are present only in the internodular tissues. Okay. Okay. We mentioned that goiter could be diffuse or nodular. Nodular again can be solitary thyroid nodule or multinodular goiter. Now, what is a dominant nodule? It is a discrete swelling in a gland with a generalized abnormality in the form of a palpable contralateral lobe or generalized mild nodularity. And what is a solitary nodule? It is a discrete swelling in an otherwise impalpable gland. Okay, so solitary nodule is a discrete swelling in an impalpable gland. That is, you are only able to palpate or clinically or even radiologically a single swelling, whereas mostly clinically though, a single swelling. But dominant nodule is the rest of the gland would be palpable with a discrete swelling. There could be either nodularity or just that the rest of the gland could be palpable. Okay, I hope you understood the difference. Solitary is a discrete swelling in an otherwise impalpable gland, whereas this one is a discrete swelling. Dominant nodule is a discrete swelling in otherwise palpable gland. And the incidence is more with solitary nodule, around 70%. What is the importance of solitary thyroid nodule? The importance is that the incidence of malignancies are more with solitary thyroid nodule. The incidence of malignancy is 20%. This is a chart from Bailey. I got it online, but it is there in Bailey. This is the rule of 12 in case for malignancies and thyroid swellings. So what is important is the incidence of malignancies is more in isolated thyroid swellings than dominant thyroid swellings, and the incidence is more with solid swellings than cystic swellings, and the incidence of thyroid malignancies are not the incidence. If it is found in male, the chances of it being malignant is more. Okay, multinodular goiter. That means there are multiple nodules in the thyroid. It is usually euthyroid, but it could be hypothyroid or hyperthyroid. When it is toxic hypothyroid MNG or toxic MNG, it is known as plumber syndrome. And MNG is more common in females. This is a picture of multinodular goiter, a patient with multinodular goiter. The clinical features, the swelling can attain large size and thus producing mass effects like dyspnea, dysphagia, hoarseness, and compression on the great vessels. Usually, patients turn up early, at least in our part of the world, due to cosmetic reasons. Uh, as mentioned earlier, most of the patients are clinically euthyroid, and though they may present with hyper or hypothyroidism features as well. And there are chances of retrosternal extension, thus causing pressure effects and superior vena cava syndrome, causing compression over the great vessels. So these are the clinical features. Now let's go to investigations. Every thyroid swelling, this is how you have to investigate. First, you should do blood investigations. Those are thyroid function tests, TSH, free T3, free T4. Okay, this is the most important test, and this is how you should begin. You should not, if they ask you for the exams, you should start with thyroid function tests. Okay, and yeah, there are other investigations such as anti-thyroglobulin antibodies, thyroid peroxidase antibodies, TSH antibodies for autoimmune thyroiditis. Why do you do free T3, free T4? Because they are the most physiologically important ones. So TSH, free T3 and free T4. And you know, in hypothyroidism, TSH would be more, and in hyper, TSH will be less. The next investigation, usually this is the order which we go in. First you do the blood investigations, ultrasonography and needle biopsy. You need to do the blood investigations before needle biopsy. Even if you get a clinically suspicious nodule, this is the format in which you should do the investigation. First you should do the blood investigations, then ultrasonography, so that, one second, I'll show you the ultrasonographic features. Yeah, there are ultrasonographic features of malignancy, such as benign nodule would be hyperechoic, whereas a malignant nodule, it would be more hypoechoic. There will be microcalcification, there will be broader irregularities, infiltrative margins, abnormal cervical lymph nodes, increased vascularity. These are the features of malignant thyroid nodules. So initially you should do an ultrasonography and then followed by biopsy. So you need the thyroid function tests before a biopsy, because if the patient is hyperthyroid, then there is more chance of the gland being vascular, thus causing increased bleeding. So before the FNAC or needle biopsy, the patient should be rendered euthyroid. So that is why this is the order in which you should do the investigations. First thyroid function tests, followed by ultrasonography and needle biopsy. Okay, this is ultrasound guided needle biopsy. So FNAC is the investigation of choice. FNAC can diagnose colloid nodule, thyroiditis, papillary carcinoma, medullary carcinoma, anaplastic, and lymphoma. But FNAC cannot differentiate between follicular adenoma and carcinoma. You do not do true cut biopsy in the neck because of the adjacent large vessels and it can injure the trachea or esophagus. So you do an FNAC in the neck, in the thyroid, and the only conditions where you do a true cut for the thyroid swelling is in case of anaplastic carcinoma and lymphoma. This is the Bethesda system of reporting of FNAC, thyroid cytology. So depending upon if it is, okay, there is no A, B, C. So it is actually A. A is non-diagnostic, B is benign, C is atypia of undetermined significance, D is follicular neoplasm, E is suspicious of malignancy, and F is malignant. So the risk of malignancy is given here, and what is how you should proceed. So if it is A, which is non-diagnostic, then you should repeat the FNAC. If it is B, if it is benign, then you just have to clinically follow up the patient. If there is atypia of undetermined significance, that is C, then again you will have to repeat an FNAC. If it is D, E, or F, that is follicular neoplasm, you cannot make out. We mentioned, right, in FNAC you cannot make out if it is a new follicular adenoma or if it is a follicular malignancy. So you should anyways proceed with the surgery. So for D, E, and F, you should proceed with surgery. Okay, after those preliminary tests, you can also do an X-ray neck, AP, and lateral view to know the retrosternal extension. CT scan if there is a retrosternal extension, CT scan of the neck, retrosternal extension. Radioactive thyroid scan with technetium 99 or iodine 123, and indirect laryngoscopy to assess the vocal cords. Okay, this is the radioactive scan. It is done to determine the functional activity relative to the surrounding gland according to the isotope uptake. So the absolute indication for which it is used nowadays is in thyrotoxicosis for diagnosis of autonomic thyroid nodule. You have a class of hyperthyroidism coming up, so more would be dealt in that class. Okay, so the only indication that we use it these days is for thyrotoxicosis for diagnosing autonomic thyroid nodule. Okay, and why is it important, the isotope scan? It can be divided into depending upon the uptake, hot nodule, warm nodule, or cold nodule. So hot nodule is when there is uptake, while the surrounding thyroid tissue there is no uptake. In case of warm nodule, the uptake is there, so does the normal thyroid tissue. In case of cold nodule, there is no uptake. Cold nodule, actually all these three are important, but cold nodule is more important because the chance of malignancy or the incidence of malignancy in cold nodule is 20%. There is malignancy incidence in warm as well as hot nodules as well, but it is more in case of cold nodules. Okay, so that is how the investigation goes. Now, coming to the treatment, medication, that is antithyroid drugs or thyroid supplements, depending if the patient is hypo or hyperthyroid. Then radioiodine ablation, again in hyperthyroidism, this will be dealt with. Then a major indication for surgery is the risk of neoplasia, which includes follicular adenoma as well as malignant swellings. Follicular neoplasms are removed since it is difficult to distinguish between follicular adenomas and carcinomas cytologically, and in MNG because of the large size such as compression, cosmesis, and suspicious nodule. Okay, this is the workup. That is, if there is a thyroid nodule, initially history and physical examination, then you should do TSH. If it is low, that is hyperthyroidism. Hyperthyroidism also you can do a scan, but you can do radioisotope scan, and depending upon if it is a hot or cold nodule. If it is a hot nodule, you do iodine ablation or surgery. If it is a cold nodule, again you should do an ultrasound. Why? Because the incidence of malignancy is more for cold nodule. If it is normal, if the TSH is normal, or if it is elevated, suppose there is a thyroid swelling but the TSH is normal, in that condition, or if the TSH is elevated, that is hypothyroidism, then you do ultrasound, and then depending upon the suspicion level, you do an FNAC, and depending on the cytology, we mentioned how to go about with the cytology. If it is non-diagnostic, you have to repeat it. If it is benign, then follow up the swelling. If it is of undetermined significance, then you can repeat, or you can do a surgery. And for D, E, and F, you can go about with the surgery. Okay, so this is an important chart. Indications of surgery, we mentioned it. Hyperthyroidism, if it is not amendable to the medical treatment. Pressure symptoms by MNG. Retrosternal extension, cosmesis, or suspicious of malignancy or thyroid malignancy. These are the indications of surgery. Okay, this is just about the thyroid surgeries in short. Okay, the first two are repeated. Lobectomy is removal of one lobe of thyroid. Hemithyroidectomy is removal of one lobe and the isthmus. Subtotal thyroidectomy is when 2 gram of thyroid remnant is kept on both sides and rest of the thyroid gland is removed. So that 2 gram is usually on the superior lobe part, okay, the upper part, near the superior thyroid arteries. That is a subtotal thyroidectomy. Then Hartley-Dunhill procedure is total lobectomy and isthmectomy on the affected side, and 4 gram remnant is left on the contralateral side. Near total thyroidectomy is the same thing with 1 to 2 gram which is left on the contralateral side. And a total thyroidectomy where the entire gland with the isthmus is removed. Okay, for solitary nodular goiter, you can do a hemithyroidectomy, and if the biopsy comes as malignancy, then you can follow it up with a total thyroidectomy. In case of dominant nodule of multinodular goiter, you can do a subtotal thyroidectomy, but there are chances of recurrence because there are multiple nodules. So in that case, again, it's preferable to do a total thyroidectomy. This again a flow chart on how to deal with the thyroid swelling. Okay, now let's come to the surgery. It's easily given, okay? There are just few points that you need to remember. Preoperatively, the patient is rendered euthyroid with drugs. The patient should be euthyroid. Now, the procedure is place the patient in a rose position. That is, the patient is put in supine position with the neck hyperextended by placing a sandbag under the shoulders. The incision is Cocker's incision, that is 2 finger breadth above the sternal notch. A curvilinear incision is placed and subplatysmal flaps are elevated. After that, the fascia between the strap muscles are divided. The fascia is divided vertically to expose the thyroid gland. Now, initially the middle thyroid vein is ligated and divided. Then the superior thyroid vessels are close to the gland. They are ligated and divided so as to avoid injury to the external laryngeal nerve. The recurrent laryngeal nerve and the parathyroids are identified and preserved, and then the terminal branches of inferior thyroid artery are ligated and divided close to the capsule. So capsular dissection of the inferior thyroid artery is done, so that because inferior thyroid artery supplies the parathyroid as well, so capsular dissection of the inferior thyroid branches, not the artery as such, the branches are done. Initially, earlier, the inferior thyroid artery was identified and it was ligated away from the gland so as to avoid injury to the recurrent laryngeal nerve, but now we don't do that. We do capsular dissection, just the branches of the inferior thyroid artery. Okay, so you have to remember the superior thyroid vessels, they are ligated and divided close to the gland to avoid injury to the external laryngeal nerve. The recurrent laryngeal nerve and parathyroids are identified and preserved, and capsular dissection of the inferior thyroid artery branches are done. The remaining lobe, this was about one lobe, so the remaining lobe is dissected in the similar fashion, and the gland with the isthmus is removed. Absolute hemostasis is attained. A suction drain can be placed below the strap muscles, and it is closed in layers. So that's about the thyroidectomy. Now coming to complications. The most important complication is hemorrhage. Primary hemorrhage is that which happens during the surgery. So that can be dealt with during the surgery. Reactionary hemorrhage happens within 24 hours. That is usually due to dislodgement of a clot. So, tension hematoma can develop deep to the cervical fascia due to reactionary hemorrhage, and that requires urgent decompression by opening the layers of the wound and taking the patient to the OT and finding out whether it is usually from the superior thyroid artery most commonly, but it could be from any other vessel as well, the hemorrhage. Another complication is respiratory obstruction. It is mostly due to laryngeal edema. It can also be due to perioperative trauma. So the initial method is to release the tension hematoma, and if it still persists, then you might have to intubate the patient for several days. Steroids are given to reduce the edema, and sometimes tracheostomy is required. Another complication is recurrent laryngeal nerve palsy and voice change. So recurrent laryngeal nerve palsy could be unilateral or bilateral, and there can also be injury to the external branch of superior laryngeal nerve. Um, so it Bilateral recurrent laryngeal nerve palsy can lead to stridor and need for intubation of the patient. The external laryngeal nerve injury can lead to changes in voice of the patient, even recurrent laryngeal nerve palsy as well. Thyroid insufficiency occurs within 2 years following subtotal thyroidectomy. This results from a change in the autoimmune response from stimulation to destruction of thyroid glands. Parathyroid insufficiency, it is due to inadvertent removal of parathyroid glands during surgery or due to infarction because of the vessel injury during surgery. Another thing is thyrotoxic crisis. That is acute exacerbation of hypothyroidism due to inadequate preoperative preparation. We mentioned that patients should be euthyroid before the surgery. This is why. Administration of IV fluids. A treatment is the administration of IV fluids, cooling of the patient with ice packs, oxygen diuretics, digoxin, sedation, and IV hydrocortisone. Specific treatment includes carbimazole, leugolcyadine, and propranolol. Other complications are wound infection, scar, hypertrophic or skeloid scars, and stitch granuloma, which can occur later. So these are the major complications. You should know about the most important complication is hemorrhage, recurrent laryngeal nerve palsy, and also parathyroid insufficiency leading to hypocalcemia. I'll just mention about the hypocalcemia in post-operative care. So post-op care includes post-op wound and drain care. The drain is usually removed within 1 or 2 days, and sutures, if present, can be removed on the post-operative day 5 or 4. Postoperative calcium levels can be measured, and the patient should be evaluated for the signs and symptoms of hypocalcemia. Usually, hypocalcemia is seen within 48 or after 48 hours of the surgery. After total thyroidectomy, thyroxine replacement is started from postoperative done. This is postoperative day 1, and this is done only if there is no suspicion of malignancy. If there is suspicion of malignancy, you don't start thyroxine, you can wait. So yes, that's all. Thank you.